Most of you know, my name is Dr. Kathy Mazzola. I'm a pediatric neurosurgeon. I operate at Morristown, St. Barnabas, Hackensack, and soon University Hospital in Newark. But what a lot of you probably don't know is that I'm very involved with the American Association of Neurological Surgeons. So that's our national organization. So within our national organization, we have something called the Guidelines Committee. And believe it or not, there are so many different kinds of neurosurgeons. We have spine neurosurgeons, we have vascular neurosurgeons, we have brain tumor neurosurgeons, and we have pediatric neurosurgeons. So I am the chair of the Pediatric Neurosurgery Guidelines Committee for the country, which means it's my job every 2 years to publish guidelines. So the hydrocephalus guidelines were published in 2014 in the Journal of Neurosurgery Pediatrics. So November of 2014, the whole journal was dedicated to the treatment and management of infants and children with hydrocephalus. And the important things to understand about the guidelines, I'll go over with you. Some of these things may be a little bit more complicated, so you could always watch the video, and if you have a question, you can call me or you can call Dawn. Dawn answers most of the questions that come into the office, and every now and then she asks me. So, and we're very, very open-minded, and we are not afraid to answer questions, even the hard ones. So, I was this is the whole team of pediatric neurosurgeons from across the country who participated in the guidelines for the 2014 guidelines. Anne-Marie Flannery was the chair, and I was the assistant chair, and now I am the chair. So I was in charge of Chapter 2, or Part 2, the management of post-hemorrhagic hydrocephalus in premature babies. So my chapter was really dedicated to infants below 12 months of age and looking at the literature that we have to make the guidelines and then coming up with some good conclusions. So I think just to start out so that you know what hydrocephalus is, hydrocephalus usually means the buildup of cerebrospinal fluid in the ventricles of the brain. Cerebrospinal fluid is a filtrate of the blood, and it's made by something called the choroid plexus. So blood goes into the choroid plexus, and the choroid plexus secretes or makes spinal fluid. And in adults, the rate of spinal fluid production is about 2 teaspoons per hour, or about 10 mLs per hour. And the rate of CSF production in infants is much less. So usually hydrocephalus is defined by large ventricles, and usually children have enlarging head sizes, so that if you have big ventricles but a small head, that's not hydrocephalus, and that does not need to be treated. That was not the hospital, was it?
It was a missed FaceTime.
Oh, I don't even know who that is. Okay, because I don't know how to FaceTime. All right, so this is a picture inside the ventricles. This is when you put the camera into the right lateral ventricle. This fluffy stuff that looks like cotton candy, this is choroid plexus. So the blood vessels come into the choroid plexus filters the blood and makes spinal fluid. Spinal fluid looks exactly like water. So if you put the camera into the ventricle, you're looking through water, looking through CSF, and it's very easy to see the structure of the ventricles. So just like the heart has 4 ventricles, your brain has 4 ventricles, 2 on the top. The 3rd ventricle is in the middle of the brain, and then from the 3rd ventricle comes the aqueduct of Sylvius down to the 4th ventricle right here. And then the spinal fluid is supposed to be circulating around your spinal cord, comes back up over the surface of the brain, and then is, believe it or not, the spinal fluid is absorbed by the big vein at the top of the head called the sagittal sinus. So why do we even have spinal fluid? Well, spinal fluid cushions the brain and helps us circulate vitamins and nutrients and other important chemicals around the brain. So the CSF does have a few different jobs to do in this space. You can actually look up different definitions of hydrocephalus, and some people will say it's when the frontal part of the ventricles get bigger. Other people say it's when the big back part. Some say it's when the ratio changes. But what we do know is when you're making spinal fluid and you're not circulating it or absorbing it, you get big ventricles. So these are big ventricles compared to normal ventricles. So it looks very, very different. In children with hydrocephalus, you also see that their heads usually get bigger faster than normal babies. So if you measure their head circumference, their head sizes are over the 97th percentile. Sometimes they have a bulging fontanelle, which is a soft spot at the top of the head. So when you see a baby being treated for hydrocephalus, the neurosurgeons and the nurses are always feeling the fontanelle. Babies with hydrocephalus, as they develop big heads, their bones enlarge and then their sutures split. So they develop what we call splayed or separated sutures. Sometimes you can see sunsetting of the eyes like this, where the eyes are looking down most of the time or all of the time. In severe cases at birth, the baby could have apnea, which is decreased breathing, or bradycardia, a slow heart rate. They could have dilated scalp veins, or they could have arching and severe irritability. For most children, between the age of 0 months and 36 months, the pediatrician or the pediatric neurologist or neurosurgeon will always be plotting the head circumference, and they have charts for girls and charts for boys. We also have charts for premature babies so that we can actually plot the head circumference from 22 weeks of gestation on. And many of these head circumference charts can be downloaded off the internet. That's not really for lay people, but if you are ever in a hospital and they can't seem to find one, you could tell them they could Google it and find it on the internet. So the reason why we wanted to do guidelines, if you look at the Institute of Medicine, and this is the National Institute of Medicine, they make recommendations to doctors saying, you know, you really should have some kind of standardized way of taking care of patients so that you can put a group of patients into a cohort and look at them and then say, how did these patients do with this kind of treatment? So we try to follow cohorts of patients and we try to come up with guidelines so that we can teach other doctors about how to take care of a certain type of patient. So it's a lot of work to do guidelines for Chapter 2, and the hydrocephalus guidelines were 10 chapters. So imagine this times 10. You do your literature search in PubMed and you come up with 213 abstracts. Each abstract is probably about 2 or 3 paragraphs. We had to read those abstracts, and then we voted using a Survey Monkey format. We decided we would accept 98 of them, and we pulled those abstracts. We pulled those 98 papers, we read the 98 papers, and then we had to make something called evidentiary tables, where we rank the significance and the strength of the study. So for example, if it was a randomized double-blinded study, that was really super good. That would be a level 1 evidence study. That means like there was almost no chance of error. Where, if it was some doctor out in Minnesota reporting on his experience of 2 patients, that was thrown out. We wouldn't even let a paper like that into the guidelines. So those papers were completely rejected. So the literature was all ranked. So this is the team of Chapter 2 co-authors. This is us after we read the 98 papers. And you can see how, sort of in this little diagram, after reading the 98 papers, 30 of them were garbage, so we rejected them. So then the literature was really based on the 68 papers. So one of the things that we realized when we were looking through the papers is some of the papers were older and used CT to assess ventricular size, where nowadays, more and more, we're using head ultrasound and MRI to look at and follow ventricular size, because we really are trying to limit the amount of radiation that we expose people and patients to. So, for example, when I was a resident in the 1990s, we would do sometimes 2 or 3 CT scans a day for a child with hydrocephalus. And that was not good, because when we follow these children later on into adulthood, we found out that many of these children go on to develop meningiomas or other kinds of lumps or growths in their brain. So we really try to only use a CAT scan for a life or death emergency. Now, what do you do if you have a shunt, right? Because shunts are sometimes an issue. If you come into the emergency room and you are lethargic and you look like something is going bad quickly, the ER doctor is just going to do a stat head CT, because he or she just wants to know, what do the ventricles look like? I need to know fast. You can do a CAT scan in under a minute. However, if you look at the Image Gently website, what they recommend is if the child is not too sick, or if the person is having a routine follow-up neuroimaging study, a picture of the brain, you should really try to do an ultrasound for an infant or an MRI. And nowadays we have something called a fast brain MRI, which literally takes 5 minutes to do. You don't have to sedate the baby. Unfortunately, the pictures are a little bit fuzzy. It's not as good as a regular MRI, but it really decreases the amount of radiation that the baby is exposed to over their lifetime. So it's important to know. And if you go into an emergency room where the doctors there don't know, you are your own best advocate, so you have to stick up for yourself, And if you feel that you or your child is not that sick, it's perfectly okay to say, I'm not sure if my daughter or son is having a shunt malfunction. Everyone in the family has a virus. He's throwing up. He's complaining of a headache. I don't think this is a shunt malfunction. Couldn't we just admit him and watch him? That's okay too, because I would rather admit someone and watch them overnight than expose them to an unnecessary CAT scan, because the CAT scan is like 200 to 300 chest x-rays all at once. So we really only do CAT scans when we are really worried about the patient or the baby. If you look at causes of hydrocephalus at birth, most hydrocephalus at birth is caused by bleeding in the brain. And we see bleeding in the brain in babies when they're premature. So a lot of babies who are born prematurely have bleeding in their brain and develop hydrocephalus. Probably the second most common is aqueductal stenosis. And aqueductal stenosis nowadays is usually picked up on prenatal ultrasound. So what happens is I see the moms when they're pregnant with the baby, and the baby has aqueductal stenosis, so obstructive hydrocephalus. The baby's making spinal fluid. It's in the lateral ventricles, it's in the third ventricle, but it's not getting out. It has nowhere to go. So while the baby's in utero, that head is getting bigger and bigger and bigger. So usually those babies are delivered by C-section, because there's no way the mom's going to be able to deliver vaginally. And then usually the first or second day of life, the baby would have a shunt placed. And we'll talk later about why you can't or shouldn't do an endoscopic third ventriculostomy for those babies. But there are a few other causes of hydrocephalus at birth. You can have a Chiari at birth causing hydrocephalus. You can have spina bifida at birth causing hydrocephalus. And you can even have a baby who has none of the above, who's completely normal, who then 2 months after being delivered has meningitis and develops hydrocephalus, or has a head trauma and a little bleed and develops hydrocephalus. So there are many different causes of hydrocephalus in infants. So in premature babies, in the super small babies, the babies who I see who are like 700 grams, super small, you can't put a shunt in them. They're too tiny. So in the old days, we used to put ventricular drains in everybody. And the neonatal ICU doctors hated us. They hated neurosurgeons. Why? Because there was a high risk and a high rate of infection. With the drain, there's no way of avoiding it. There is a certain risk of infection. So then we developed something called a reservoir, or a ventricular access device, and I'll show you the difference between those two. So this is a baby who has a drain that's coming out of his or her head. It's tunneled under the skin and popped out here. The drain is yellow because it has antibiotics in the tubing. So there's an antibiotic called clindamycin and rifampin in the tubing. And just adding antibiotics to the tubing reduced the risk of infection from about 20% to about 5% with ventricular drains. So every now and then we do advance our technology a little bit to make life a little bit safer, a little bit better. So this is what a ventricular drain looks like. You can see the tube is connected to, this is called a buretrol, and this is how we can control how much spinal fluid is drained out of the little baby's head. Another way for premature babies, we remove spinal fluid. We do a lumbar puncture where we put a needle into the CSF space and aspirate or suck out CSF from down here. This is called an Ommaya reservoir. This is what we were talking about before. When you take the tube, it goes into the ventricle, and that tube is connected to a little dome. It's a little plastic button or bubble. And then whenever you want to suck out CSF, you clean the skin over the bubble, put the needle in there, and pull back and aspirate CSF. The risk of doing any kind of aspiration of CSF, even a shunt tap, is infection. So you really have to make sure that if someone's putting a needle into the spinal fluid, whether it's through a spinal tap or an Ommaya tap or a shunt tap, they really, really, really have to clean the area with betadine, chlorhexidine, something to kill the bacteria on the skin. Because we all have bacteria on the skin. We have staph, Lacoccus, we have streptococcus, teenagers have propionibacter, acne, we have bacteria all over our skin. That's why for shunt taps and for any kind of tap, you really have to have clean skin. So one of the things that we found is that if we do something called a ventriculo-subgaleal shunt, less risk of infection compared to an Ommaya, that little reservoir, and less risk of infection compared to EVD. The ventriculo-subgaleal shunt is a tube that goes from the ventricles, comes out through the bone, and it just ends right here. So it's an open end here, open end here. And so what happens is when you put it in, the CSF comes out of the ventricles and accumulates under the skin. So yes, there's a decreased risk of infection, but many parents do not want to see that CSF collection on their baby's head because it's very unnerving. It's very unusual looking, and it doesn't absorb as fast as you would like it to absorb, but it does have a lower risk of infection. In the old days, the neonatologists would do spinal taps every day, but what we found with a level 1 recommendation, so that's the highest strength of clinical certainty, is there is no benefit in daily spinal taps. Not only is there no benefit, but there's danger. So if you do spinal taps every day, there was a higher risk of shunt infection. And there was no benefit at all seen in doing daily lumbar punctures. So we're actually changing the way the NICU doctors are managing hydrocephalus now in the little babies. Probably in the early 1990s, someone had an idea that if a baby was born and had bleeding in the brain and there was a huge blood clot, if you could dissolve the blood clot, then maybe the hydrocephalus would go away. So they started injecting something called TPA or urokinase or streptokinase, and those are clot-busting drugs. They're enzymes or proteins that break down clots. We use these drugs when older people come in with a sudden onset stroke and they do a MRI or MRA and they see a big blockage in like your carotid artery. Sometimes we'll administer urokinase to dissolve the clot to prevent a permanent stroke. So we were injecting these drugs into babies' brains. Unfortunately, it didn't work out so well for the babies. Many of them died because of secondary bleeding. So we do not recommend injecting any clot-busting drugs into the ventricles of babies. So this is shunt catheter coming into the brain. You can see the ventricles, and this is bleeding that was caused by injection of urokinase. We also, in history, we have tried different drugs. Diamox, or acetazolamide, is sometimes used by neurosurgeons to try to temporize CSF. Acetazolamide decreases the production of cerebrospinal fluid, and furosemide is Lasix, so that makes you urinate a lot. So sometimes there are medications we could try. However, what we found in the studies that we looked at, level 1 strength, there was no benefit of either drug in treating hydrocephalus. So it's either get that shunt in there, get the shunt to work, forget the drugs. They're not going to work. We then looked at how big does a baby have to be to put the shunt in? Or if the baby had a bleed in the spinal fluid, like you see here, how clear does that spinal fluid have to be? So if you tap the Ommaya this day, Monday, let's say, and there was a lot of blood cells, could you put the shunt in Tuesday? There's some less blood cells in there. Or do you have to wait for Thursday for the spinal fluid to be perfectly clear of red blood cells? So unfortunately, even though we looked at so many papers, there is no good evidence that there's any specific parameter to guide neurosurgeons about when to put the shunt in. Again, we looked at different weights of babies. There were 2 class 3 studies that recommended shunting babies once they gained up to 1,500 grams. So that's 1.5 kilograms is a goal weight. But the protein, the cell count, the glucose, there was nothing else to help us there. So let's talk about this idea of doing the third ventriculostomy. In the 1905, 1910, there were no shunts. No one knew how to make little teeny tiny plastic silicone tubes to put in babies' heads. So there were no shunts. And the way they treated hydrocephalus then was, what we would consider barbaric. They would make a little incision, make a little hole in the bone, put a straw or a tube in there, drain off some spinal fluid. Sometimes they would leave the tube in which case the baby almost always died of meningitis. But sometimes they would put, they would try to look in the ventricle. They would try to look in there and make a hole in the bottom of the third ventricle. Well, now we have much better cameras and our optics are much better. So this is, again, is a picture looking into the right lateral ventricle. This is the foramen of Monroe, which brings you into here. This is the third ventricle. This is the front of the third ventricle and the back of the third ventricle. Here you're coming down with a probe. You pop a hole right here. Then you blow up a balloon in the hole to dilate or enlarge the hole. And then you pull out. And you can see there's a huge hole now in the bottom of the third ventricle. Well, that hole will allow the spinal fluid to circulate, but if the baby never learned or cannot absorb the spinal fluid, there's no sense in popping the hole. You're just creating a new pathway, but the baby still can't absorb the spinal fluid. So, wait, let me go back. So there was a level 3 recommendation saying there's not enough evidence right now to recommend endoscopic third ventriculostomy for infants with post-hemorrhagic hydrocephalus. There's just not enough evidence. And again, this is how we do it. We put the camera into the right lateral ventricle, go through the third ventricle, and pop the hole there at the bottom of the third ventricle. We looked at some studies. There was, for example, there was a review of 52 ETVs in 49 babies with hydrocephalus. Most of them had aqueductal stenosis. Only 7 patients had post-hemorrhagic hydrocephalus. Of the 7 babies, 6 ended up needing a shunt. So 6 out of 7, or 85% of babies, needed a shunt anyway after an ETV. So this guy on the right, he's my friend Ab Kulkarni. So Ab looked at all the shunts that have been done in the University of Toronto over the years. And he came up with something called the ETV, or endoscopic third ventriculostomy success score. And this is how we can predict how a baby's going to do. So if you have a term baby who is less than 1 month old, they get 0 points. If that baby had a bleed or a hemorrhage, they get 20 points. And they had no previous shunt, they get 10 points. So that baby only has a 30% chance of the ETV working. ETVs work best in kids over 16 with aqueductal stenosis or a tectal tumor who had no shunt. Those kids, if you have those kids, 50 plus 30 plus 10, those kids have a 90% chance of an ETV working. So ETV is a great surgery if you have the right patient. You shouldn't just do it in babies because it's something to do, because the data shows it doesn't really work. So ETV cannot be recommended for infants with post-hemorrhagic hydrocephalus. We don't recommend routine spinal taps or lumbar punctures. Injection of clot-busting drugs is not recommended. You can do an ETV for older infants if you really want to try for aqueductal stenosis, but chances are they're going to end up needing a shunt. It just doesn't work that well in babies. I wish it did. The other thing that we looked at that we wish we had a better answer for is how small should you try to make the ventricles? Now, there are some babies who, when they were born, had humongous ventricles, and you put a shunt in, and the ventricles get super teeny tiny. Then there are some babies who don't have good communication of their CSF. They may have an obstructive hydrocephalus, and you may have one ventricle or two ventricles that are still big. What do you do with those babies? Should you do like 10 more surgeries trying to make those ventricles smaller? So, but you can have babies who have ventricles this big who get down to here. So you can, over time, drop the size of the ventricles. So this is a study that was in a single institution. So it was one hospital. They looked at 228 preemies who had post-hemorrhagic hydrocephalus, and the babies were followed by ultrasound. And they found that if the ventricles didn't get smaller, if the ventricles stayed big, there was a 5 times increase in spastic cerebral palsy or spastic diplegia. Now, for some reason, what we do know is that even with big ventricles, many of these kids have good cognitive or IQ function. It's that they have tightness in their legs, tightness in their muscles, and that's called spasticity. So we really do try to get the ventricles smaller as quickly as we can, which in some cases can cause a little bit of trouble, because if you have a child who has huge ventricles and a very thin brain that has been that way for a while, and you're sucking the fluid out of the ventricles, the brain can drop. And then if the brain drops, you have a fluid collection on the outside of the brain that you have to remove before you can change the ventricle size again. So you really, for many kids, it's like riding a skateboard. You're doing really well, and then you fall off, and you have to go back to the OR. But over time, this is the goal. This is the goal. You want to make the brain look as normal as possible, and can it be that way for everyone? No. There are some people who have one ventricle's bigger, and no matter what you do, that ventricle stays bigger. And it's not the end of the world, but it's our job as neurosurgeons to make sure the child's gaining milestones, doing well neurologically, and then we should try to do the best we can do with their shunts. So again, this was just another study that showed that ventricular dilation had more or stronger association with neurodevelopmental outcomes. So the smaller the ventricles, the better the neurodevelopment would be. And again, cognitive development, again, it's worse when the ventricles stay big. So that's why neurosurgeons try so hard to get those ventricles back to normal size. And sometimes we're very good at it, sometimes we're not. The reason why it's important, this is called a DTI MRI, a diffusion tensor image MRI. And it looks at the water content in some of the nerve fibers. And you can see the millions and millions of nerve fibers that come down that are right around the ventricles. So this is the way the acquisition or source images look. This is the way it looks put together in a 2-dimensional or a 3-dimensional view. And these are source images from a baby with severe hydrocephalus. So you can see how those fibers are really pushed out to the side when the ventricles are so big, like that. And so for neurosurgeons, we're trying to get the pressure off those nerve tracts. So like my dream for every child with hydrocephalus would be you put in a shunt like this, and a few weeks later, this is what it looks like. Does it happen that way all the time? No, it doesn't. I said that's my dream. Sometimes you put the shunt in and one ventricle gets smaller, but not the other ventricle. Sometimes you put the shunt in and all the ventricles seem to get smaller, but there is one collection of CSF that's not getting smaller, like the temporal horn or something. There's no magic way of making that better unless I go and put another catheter in there, or put a camera in someone's head and try to poke through. But whenever you do something like that, there's risks. There's a risk-benefit ratio. I wish there was a way I could operate and have no risk, but it's not real. And poking holes in people's brain, believe me, there's nothing that I do in a cavalier manner. I feel it. I feel the responsibility. I need to retire soon and someday because I am getting more and more gray hair over this. But it does, as a pediatric neurosurgeon, sometimes I see kids like this with huge ventricles and almost no brain, and whoever put their shunt in forgot to tell mommy that, oops, the catheter is not going into the ventricle. Come on, that baby needs another surgery to put the catheter in the ventricle. You can see where they made the hole in the skull, and instead of going into the ventricle, the tube went over the surface of the brain. You could leave this shunt in here for 30 years. This CAT scan is never going to look any better. So you really, as parents, you need to understand a little bit about hydrocephalus and ventricular size so that if your neurosurgeon shows you a CAT scan or MRI like that, you can say, well, what are you going to do to make it look a little bit better? Because we'd like it to look a little bit better. So many parents ask me, what about stem cells? So I am also, for the AANS, the American Association of Neurological Neurosurgeons, I'm the chair of the ethics committee. They don't choose liars to be chairs of the ethics committee. They just don't do that. And they only choose chairs when you've been around and you're very old. Well, maybe not so old. So ethically, I tell parents, listen, you can go to South America, you can go to China, you can pay $100,000 for stem cell therapy in China. You might as well take that $100,000 and throw it up in the wind because it's not going to work. If you do stem cell therapy, it has to be done while the brain is developing, sooner rather than later. Up until the age of 7 years is your best chance of having some kind of change. And if there are stem cells, that would work for your baby. So there are only 2 places doing stem cell therapy right now, Georgia and Duke. And in Duke, what they're doing is they're taking umbilical cord blood and they're injecting it into the ventricles of babies with hydrocephalus who are born prematurely. So that is what they're doing there. Is there any guarantee at all that this will work? No, there's no guarantee. If and when I go back to Newark, because I trained in Newark and they asked me to come back there now to teach, if and when I go back there, one of my dreams is to have a lab, and not that I don't like little rabbits. Rabbits are cute, but I'd like to take premature rabbits, baby rabbits who are born prematurely, who have had a bleed in their brain, and I'd like to inject their little brains with stem cells to see if we could better predict when to do those stem cell injections and how that would affect spasticity in the legs for kids with cerebral palsy. So we'll see. That kind of lab, though, would take me at least 3 or 4 years to get that going. It's not going to happen anytime soon. So the rest of the hydrocephalus guidelines, we looked at hydrocephalus and shunts for older kids. So what about endoscopic ventricular catheter placement? There are some of my friends who are pediatric neurosurgeons who put a camera in the brain every single time they do a shunt. Studies show no benefit. Insufficient evidence to recommend the use of an endoscope for ventricular catheter placement. Level 1 recommendation, no benefit for doing it every single time. If you use it selectively for a child who has slit ventricles or tiny ventricles, yes, then there is a benefit. And the same thing, ultrasounds and electromagnetic navigation, there are options, but you really have to pick your patients well. For older children, you can use an endoscopic third ventriculostomy if they have aqueductal stenosis or a tectal tumor, and those kids do better. Is there a better shunt? There's some neurosurgeons who say, oh, I only do Medtronic shunts. And other neurosurgeons say, oh, I only do Codman shunts. There's no company that's better than another. They're all the same when we look at the data. We also looked at, and this really confused me, there's not enough evidence right now to recommend the use of a programmable valve versus non-programmable. So both are options. It's a level 2 option, but why programmable? And this is why it should work. So in little babies, they have low pressure in their head. You want to set the pressure relatively low. And then as they get older and their ventricles get smaller, you want to slow down that shunt. You don't want them to be over shunted. When I see adults with teeny tiny heads and shunts and slit ventricles, I know that they were shunted in the 70s or 80s or early 90s, and they had an ultra low pressure shunt that was not programmable. The only real disadvantage of the programmable shunt is that we have to program it. After an MRI, we have to check it, we have to program it, we have to make sure the setting didn't change too much. There are even different kinds of programmable valves. The one I was brought up with is over here, the Codman programmable valves. These series of valves are the Medtronic Strata programmable valves. They're both excellent. There's really no difference. The Medtronic programmable valve has 5 settings. The Codman has like 20 settings, but there's really no difference. Newark, we were a beta site in 1993 and through 95 for the Codman programmable valve, so I just grew up with that. Yes, you should give pre-op antibiotics all the time for every patient within 30 minutes of skin incision. Not when the kid's on the floor, not when they're leaving the PICU, but in the OR, right before the skin incision, that's when you should give the antibiotics. Should you use antibiotic shunts? Yes, you should. When I came out of fellowship and I started going to Hackensack, the head neurosurgery nurse, gave me such grief every time I shunted someone. She said, you know, Dr. Mazzola, whenever you put one of these antibiotic impregnated shunts in someone, it costs $800 and the normal shunt is $400. And I was like, yeah, but the antibiotic impregnated shunts reduce shunt infections. But I had no data. But now we do have data. And there's a lot of published data. Unfortunately, right now, even though it's published, it's still only level 3 data, but it does show that antibiotic impregnated shunts do make a difference. It really reduces the infection rate. What to do with a shunt infection? Again, in my dream world, we would never have a shunt infection, ever. But it happens. You know, I've seen kids who've had a same shunt for 20 years, had dental work, the bacteria got into their bloodstream, and where did they land? On the shunt. So you had a shunt for 20 years, no problem, and now you come into the office with redness going down the shunt tubing. So the way I was taught is take the whole shunt out because it's all infected and the bacteria stick on the tubing, put in a drain, wait till you have 3 negative cultures from the CSF, and then put a new shunt in. However, some of the older fashioned neurosurgeons would take out the part in the belly or in the lung, leave the part in the head, and just put a new distal catheter. The way I was trained is you got to take the whole thing out. But like when we look at the data, both are options. There's insufficient evidence to recommend shunt externalization, which is taking part of it out, or complete shunt removal. So you could do either one really, but I was not trained like that. So intrathecal antibiotics, some hospitals do it, some hospitals don't do it. It is an option, so it's a level 3 option to inject antibiotics through the shunt tubing to try to clear a shunt infection. But if you're injecting antibiotics into the CSF, it can cause scarring in the brain, which can theoretically also lead to seizures. So it's an option, but it's not something I would try right off the bat. What about shunt entry points? So I was taught to put it in the front because it avoids a lot of choroid plexus. Other neurosurgeons were taught to put it in the back because it avoids choroid plexus. There's no good answer. So both are acceptable with a level 3 recommendation. There is no data to show either way. So first, when we do these guidelines, we review the literature, we make the guidelines, we publish the guidelines. They're usually published in Journal of Neurosurgery or Neurosurgery. And then it's our job as the guidelines team to review the guidelines every 5 years to see if there's any new data, any new publications, any new studies. And so after the hydrocephalus guidelines were published in 2014, this here is November 2016 cover of Neurosurgery. So I was the head of that, and we got 6 chapters about how to treat babies with flat heads or asymmetric heads. So we just published our 2nd set of guidelines, and now we're working on the spina bifida guidelines. So like my major aggravation right now, we listed 10 questions we wanted for spina bifida. There's only so many volunteers. Like you could have 2,000 pediatric neurosurgeons, you get the same 10 people volunteering to help every friggin' year. Every project, it's the same people. So, and there's only so much time we have. I mean, those are my 5 kids. So between those 5 kids and all of my kids that are my patients, I don't have a lot of time. And I'm working on the guidelines, and I'm on like 100 other committees. So as fast as we work, we get things done. So spina bifida, we went from 10 questions to 5 questions. We're gonna do, does in utero closure reduce the rate of shunt placement? Does in utero closure of myelomeningocele increase the baby's ability to walk by 3 years of age? Does in utero closure increase the risk of spinal cord tethering? And there were 2 more things. Oh, no, 2 more things. There was 2 more things. Oh, I know. Is there any benefit to doing the closure of the myelomeningocele within the first 24 hours? And do antibiotics have to be given within the first 48 hours for myelomeningoceles? So we're looking at those spina bifida guidelines. I am on the in utero closure and tethering chapter, so that is my chapter that I'll be the lead author on. We just did the literature search. We have 2 different librarians. We're working with librarians from University of Madison, Wisconsin, UW, and the USFL, the University of South Florida librarians. So we just got some of the searches back. Then we have to merge the searches to get out the duplicates. Then we have to read. I think I have 98 abstracts for my chapter, so we'll see. We're getting there. So anyway, so that's basically how we come up with guidelines, and that's what we do as pediatric neurosurgeons. So if you have any questions, you could always watch this very exciting video presentation. Thank you, Brendan. Brendan will have it up somewhere sometime soon.